Right. Welcome, everyone, to this week's Grand Rounds. We are fortunate to be joined by some local experts in Julianne Wojciak and Vasanth Vedantham, who will be talking to us about the genetics, incorporating genetics into cardiovascular care. And we are very fortunate to have these local experts chime in on what I hope will be some pragmatic tips on how we can apply genetics at UCSF. So I'll just start off with a couple introductions for each. Julianne Wojciak is a licensed genetic counselor specializing in cardiovascular genetics here at UCSF. She has been the lead genetic counselor for UCSF's cardiovascular genetics program since 2010. This clinical service provides comprehensive cardiac and genetic care for patients and families with inherited heart disease, such as cardiomyopathies, arrhythmias, aortopathies, dyslipidemias, congenital heart defects, as well as unexplained sudden cardiac death. Julianne is also involved in numerous cardiovascular genetic research studies at UCSF, focusing on discovering novel genetic susceptibility factors and directly translating research findings to patients and family members to benefit from potentially life-saving medical care. Dr. Vasanth Vedantham is a UCSF Associate Professor of Medicine and cardiac electrophysiologist. His research explores the origin of heart rhythm in normal and diseased hearts, with particular interest in the cardiac conduction system, inherited arrhythmias, and the impact of genetic variation on heart rhythm-related traits. Clinically, he is focused on inherited cardiovascular disease as part of the Cardiovascular Genetics Center, in addition to his work in clinical EP. So thanks both for joining. I'll let you take it away.
Great, thanks. Great to be here and great to have this opportunity to present. So the goal of this talk, as Dr. Salazar said, is going to be primarily educational and ideally for those who don't have a framework for thinking about how to incorporate cardiovascular genetics into their ordinary patient care. Hopefully this lecture will give you that. And we'll also share just some data, internal data from UCSF, so you get a sense for the scope of what we're doing here and sort of what our process is like. So here are the main objectives. So I'm just going to start with really basic practical genetics principles that are relevant to cardiovascular care, and then we'll go through kind of our approach to genetic testing here at UCSF, who we should test, why we should test, the process itself, and how we select and interpret these tests. Then we'll share some data about the cardiovascular genetics cohort at UCSF. And just in the very end, I'll just give a really very just sort of touch on challenges and opportunities that will hopefully we'll all be presented with in the near future. And that's it. So again, I'm going to start with the very basic. So as all of you know, DNA is the molecule of life. And I think the relevant numbers for this talk are that the genome really has 3 billion base pairs. They're sort of arranged into chromosomes. And there's about 2 meters actually in length of DNA. And of those within that genome, there are about 20,000 protein coding genes. And it's probably worth mentioning that the protein coding part of the genome is, in the 1 to 2% range of the genome. There's a lot of other stuff in there. The key points, if you take 2 random individuals, DNA sequence is about 99.9% identical, which seems like a lot. But on the other hand, if there's 3 billion base pairs, it comes out to about 3 million, differences on average between individuals. And, that's where all the kind of individual variation lies. And obviously, individual variants can be benign or pathogenic. And when we think about variation in the genome, so obviously you can have large-scale variations, duplications of chromosomes or parts of chromosomes, trisomies, things like that, which are on a very large scale. You can have copy number variations where large stretches of the genome get duplicated or deleted. And this will typically involve, megabases to 10 kilobases, often multiple genes and intergenic segments. And then finally, you can have expansion of a single gene or a single locus, which will typically involve 1 gene and be a few kilobases. And then at the very end, you get sort of sequence changes, small, little tiny deletions. And pretty much 90+% of what we do in cardiovascular genetics really is focused on the individual sequence variation level. And so the consequence of that is that a lot of the larger scale of variation, those aren't things that we are commonly testing for. Typically, those things would present as syndromic disorders and might get worked up by medical genetics. On occasion, we search for those things, but for the most part, we're looking for single base pair changes, small deletions, truncations, things like that, splice variants. And cardiovascular genetics is, I think, unique and unlike other areas of clinical genetics because there are a couple of major challenges for the clinician who's thinking about how to interpret, say, a family tree, or how to think about how to approach testing in a given patient. So if you look on the left, one of the rules, and we'll come back to this probably over and over again in this talk, is there's a lot of reduced penetrance and variable expressivity. So what that means is oftentimes you'll have patients who have a genotype but don't have disease, and that's incomplete penetrance. And sometimes you'll have patients who have a pathogenic gene or pathogenic variant, and within the same family, people have very different phenotypes. So on this pedigree on the left, you'll see wherever you see the black dot, that's a patient who actually has the genotype. And so sometimes you'll see these people, some of them have syncope, someone has dilated cardiomyopathy, someone else just has shortness of breath, someone's unaffected, someone else has syncope, and then you might have a red herring where there's someone in the family who had cardiac arrest but doesn't have the genotype, right? Or can't be ascertained. So this sort of thing creates a problem when you're trying to figure out who should be tested. Similarly, there's a lot of overlap. So individual pathogenic variants can often give rise to different phenotypes. They affect different parts of the cell, and one and the same gene can sort of cause various things along the spectrum of arrhythmogenic cardiomyopathies, hypertrophic cardiomyopathy, dilated, arrhythmogenic, et cetera. So we're faced with the fact that the family history is often unreliable and vague. So one thing to do is, patients will often say, yeah, I have someone in my family who had heart disease, and they have this sort of vague story, but it's really critical to dig out the medical records and find out exactly what happened. People are often told someone had a heart attack, which could mean many things. And we paid a lot of attention to sudden accidental deaths. As I said, we try to do very careful assessment of relatives who have symptoms to try to understand if they've had appropriate workups. And oftentimes family histories are just negative, even in patients that have genetic lesions. So this is really the key points for the challenges that sort of face us in cardiovascular genetics. So the history of this field, I won't go into this all that much. These are just some milestones that I've sort of diagrammed here. So the figure is taken from sort of a review of the Human Genome Project from its start to its end. And I've sort of overlaid a few key things that occurred in the cardiovascular field over that time. I want to make a couple of points. So one is when the first commercial testing was developed, panels consisted of about 3 to 10 genes, and we're looking at $10,000 for a panel, often Sanger sequencing based. But as next generation sequencing came online and more genes were ascertained, now a typical panel, we can send a panel for 300 genes, and it costs about $250. So it's a remarkable decrease in cost over the last 20 years. The other thing I just want to point out is just how much we're learning about the genome. So everyone knows, right, the Human Genome Project, we think of it as, okay, well, it was completed in 2000, but really the first full genome, the full drafts of the completed genomes, realignments, adding new sequence, people are still adding stuff to the genome, reassembling it even in 2022. So there's a lot that we're still learning about it. It wasn't all done in 2000. So now I'd like to turn to the question of who really should be tested. And so here's a list essentially of Mendelian diseases with established gene panels. So familial hyperlipidemia and other dyslipidemias, vascular diseases. So Marfan's, Loeys-Dietz, aortopathies, vascular Ehlers-Danlos, pulmonary hypertension, long and short QT, progressive cardiac conduction disease, et cetera. We've got obviously all the disorders of the myocardium, hypertrophic, dilated, dystrophic, arrhythmogenic, non-compaction, and restrictive. And then various structural heart disease like bicuspid valve, mitral valve prolapse, and isolated congenital heart disease. We now have gene panels for most of those things. And I think if you kind of add it all up, cardiovascular, Mendelian cardiovascular disease is actually surprisingly common. And it's generally underdiagnosed, largely for the reasons I mentioned already, variable expressivity and the incomplete penetrance, et cetera. So there are a lot of people walking around with Mendelian pathogenic mutations that we don't know about. So here's just a slide that comes from general, guidelines on how to approach genetic testing. I'm obviously not going to go through the flow sheet. I think the main point is really, suspect when to suspect the diagnosis and then getting the family history. And once you have those two things, then everything sort of flows from that. So here at UCSF, I would say anyone with a clinical diagnosis of an inherited cardiovascular condition. And I would say atypical or borderline cases where a genetic test might actually help. Family history, obviously, even in an asymptomatic person, can sometimes be an indication for testing. Family history of sudden death, we have a specialized clinic for that that Dr. Sang runs. And so if you ever need to make the referral, it's just a simple APEX referral, ambulatory referral to cardiovascular genetics. So I want to introduce a case here. So this was a 20-year-old patient with myocarditis who came in with a positive troponin and chest pain, normal coronary arteries, and a mildly reduced EF, and some PVCs and NSVT. He had had recurrent chest pain over the years, but that's the only past medical history. And when the family history was obtained, the interesting finding was that his mother died at age 45 of sudden cardiac death, and he has two siblings that have cardiomyopathy. He underwent a biopsy that was nonspecific. You can see the EKG at the right, pretty normal with a little bit of QRS fragmentation. And the MRI shows sort of a lot of delayed enhancement, but in a pattern that would be consistent with, acute myocarditis. So this patient was started on goal-directed medical therapy, got pain control, and was discharged with a life vest for further workup. But because of the family history, genetic testing was sent, and actually a very complicated result, which, and Julianne later will talk a little bit about how to interpret genetic testing results. But the interesting thing is this patient had a known established pathogenic mutation in DSP, which is a gene that causes arrhythmogenic right ventricular cardiomyopathy or arrhythmogenic left ventricular cardiomyopathy. In addition to other things like a pathogenic TTR variant that is unlikely to be responsible for their phenotype, as well as variants of unknown significance that require some thought. But the pathogenic DSP was sort of interesting. And as many of you know, DSP is part of the desmosome, and it is part of the molecular structure that anchors one cardiomyocyte to another. And when there are mutations in any of these genes, you get arrhythmogenic cardiomyopathy, presumed due to the damage, the damage that cells incur when the intracellular junctions are weakened. And around the time this patient was genotyped, I should say, work was coming out establishing, patterns of familial recurrent myocarditis triggered by exercise or even in the absence of exercise in patients with DSP mutations. And subsequent work has demonstrated that if you have patients with DSP mutations who have inflammation, you can see the Kaplan-Meier curves split apart pretty dramatically. So those with inflammation or myocardial injury have a much worse prognosis than those without. This patient ultimately actually ended up having a cardiac arrest while not wearing a life vest, which is sort of very tragic. But the case illustrates the importance of thinking about doing genetic testing, even in circumstances where you might not ordinarily. And related to that point, in general, genetic testing is pretty grossly underutilized. So this is data from a recent paper. I can't say, the data is derived from culling a large EMR using, an automated algorithm, as opposed to sort of manual curation. And essentially, they looked at people who meet formal guidelines for genetic testing based on Heart Failure Society of America, AHA, ACC, for hypertrophic or dilated cardiomyopathy. And the adherence to genetic testing guidelines was incredibly low, like 0.32%, 1.9%. So it's really in HCM and DCM, and the numbers were pretty similar. And even if these numbers are way off, even if they're off by a factor of 10, it's still very gross underutilization of genetic testing. So it's just something to consider for all these patients who are out there and who aren't being tested and aren't getting genotype appropriate treatment. There are less common circumstances where we also would encourage you to think about genetic testing. So I mentioned relapsing myocarditis, peripartum cardiomyopathy. Cardiomyopathy out of proportion to risk factors. So, someone might have had an IMI 10 years ago, but if they have an EF of 20% and, global dilated biventricular heart failure, it's worth considering a genetic cause. And those patients who have long QTs in the hospital, right? Someone who gets on whatever it is, methadone and an antifungal, and then their QT goes out, they might have torsade. Many of those patients actually have congenital long QT syndrome that's normally concealed. And then considered even in lone AF patients, athletes AFib. And if you look at published literature, in each of these conditions, the yield of genetic testing is about 10%. And given the value, which I'll get into in a little bit, of genetic testing for the proband and for the family, if you got to sequence 10 people to find someone, that's a pretty good yield, given how cheap it is to sequence people. So why should we test? So there's obviously a lot of impact. So for the proband, you can establish a diagnosis, confirm a diagnosis, change a diagnosis. There's genotype-specific treatment. You can inform prognosis. And there are some patients where the genetic diagnosis doesn't yet have a lot of impact, but in the future could as we learn more about the genotype. For the family, obviously you can guide risk and surveillance. And that means identifying people who need surveillance, but it also means releasing people from surveillance who otherwise might be anxious about having a family history of disease. You can also help with family planning, and you can give guidance on lifestyle and exercise. And in some instances, it affects people's professional choices. And, as I said, it can affect the psychology and well-being of family members. So here's an example. This is a patient we saw, 41 years old, just an athlete with palpitations who, came in after a half marathon and a bunch of beers with AFib. So it really, this is sort of like some combination of holiday heart and athlete's heart, whatever. But interestingly, he had a father with AF at 60 and a brother who had AF at 59. EKG just showed atrial fibrillation and otherwise normal labs and echo, and he was cardioverted. But, because of the family history, he underwent sequencing. And if you actually look, what are the results of genetic testing for early onset AFib? Actually, the yield is reasonably high. When you look at people who are sort of in this kind of 30 to 40% age range, you get a yield of about 10%, and it obviously goes higher as you get younger. And when you sort of think about what disorders you're actually picking, what disorders the genes that you pick up are associated with, they're disorders that actually have significant consequences, right? DCM, HCM, arrhythmogenic cardiomyopathy, long QT syndrome, they're things that, the AFib is sort of the canary in the coal mine. And if you can detect it now, you could potentially save a life. You can have, it'll have huge impact on the patient and their family down the road. So in this patient, we found a mutation in titin, which, as many of you know, it's the largest protein in the body, and it sort of spans the entire myocyte from Z disc to Z disc. And the most common titin mutations occur. They truncate the protein in the A band and result in an incomplete protein product. And that predisposes people to AFib, cardiomyopathy, dilated cardiomyopathy, and arrhythmias. And so in this patient actually underwent AF ablation and did well, but because of the titin mutation was surveilled very closely. And he eventually developed some polymorphic non-sustained VT and an EF reduction and received appropriate therapy. So it's an instance where this is someone who might have had a long delay to diagnosis and might not have had at-risk family members screened. And if you look at early onset AFib and pathogenic variants that are found, titin is the most common, but you can see you find a lot of variants in genes that are actually really important for, that would be really useful for patients and families to know about. So what's the yield of panel-based testing overall? So there have been some recent estimates of this, and obviously this is going to depend on the threshold for testing, the population that you look at, and various other factors. But in general, across the board, it's somewhere in the 20 to 30% range for most disorders. And so if you think about things like number needed to treat and or number needed to make a diagnosis, number of tests that is to make a diagnosis, and the impact of the test, oftentimes this is a very cost-effective thing to do, especially given the number of and things that we pay for. So the impact of this can be pretty great. And so oftentimes my personal threshold to order testing is rather low. So what's the utility of genetic testing for the proband? Again, a lot of genes actually have both predictive value and gene-specific therapy. And so I'm not going to go through this table at great length, except to say that we now know enough about several specific genotypes that, for example, in the ICD guidelines, as you have an indication for an ICD if you have an EF less than 35% and meet all these other criteria. But for some genotypes, like lamin A, for example, if your EF is less than 45, but you meet some other criteria, you have a class 2 indication for an ICD. Likewise for phospholamban or FLNC. And then there's also genotype-specific therapies that are available, exercise restriction for some patients. So it's actually a very important and consequential thing to make the genetic diagnosis in most patients. And then what about for families? Well, this is from a paper from Carolyn Ho's group on an HCM family. And here is the proband, you can see here, who is positive for a HCM gene mutation and has HCM. And the red arrows basically show you all the at-risk family members, right? Siblings, as well as all the first-degree family members who are at risk. And any first-degree family member by guidelines would need longitudinal screening. And so the value of doing cascade screening, of then bringing in all those family members and testing all the at-risk ones individually is, well, this sibling is negative for the gene. So this sibling plus this sibling's children can all be released from testing and surveillance, which is a big relief for them. And then these two are positive. So now you know exactly who needs surveillance, who needs guidance on exercise, who might need preventive treatment. And then you have one child who's negative and doesn't need follow-up. So again, predictive testing is extremely helpful for the family. So now I'm going to turn it over to Julianne. I'm going to still drive the slides, but I'll let Julianne take over and tell you about the genetic testing process.
Well, thanks, Vasanth. So multiple professional guidelines really advocate for the multidisciplinary care of patients and families with genetic heart disease, just because there are so many complexities, and the complexities change really throughout their life as they age. This is a guideline from the AHA in 2019 around creating centers for the care of patients with genetic heart disease. And these are just some snapshots of sort of illustrating the complexity and the comprehensive nature of the evaluations. They come into the center with detailed records, see cardiologists and electrophysiologists who specialize in the care of patients with these conditions and have access to sort of state-of-the-art advanced diagnostics. Genetic counseling and testing are integrated within the evaluation and used to initiate appropriate management and gene-specific therapies in some situations, as Vasanth mentioned. There's a whole team of specialists that are needed for the care of individuals with these conditions, as well as research opportunities. And so really our program is sort of designed after these sorts of guidelines, and there are a number of these across the country. Next. We wanted to take a second to talk a little bit about genetic counseling. We're sort of a mysterious bunch, but basically what we are is healthcare providers who specialize in the genetic care of people with inherited disease. So what does this mean? We spend a lot of time with patients and families collecting very detailed family history data and confirming that data. As Vasanth mentioned, family history can be very vague and unreliable, so we often need autopsy reports, medical records, tracking down genetic test reports to be able to provide accurate assessment for the patient in front of us and their family. This information goes and informs test selection. It's not uncommon that a family history actually will change the test that we order, and we wouldn't have ordered it if we didn't have that detailed family history. Education about what the individual condition is, the inheritance, the genetics, for getting informed consent from a patient, and interpreting the variant data. We also spend a lot of time explaining the test results and the implications for the patient and the family, both from a medical and psychosocial perspective. For patients, excuse me, for patients who are in reproductive age, we spend time talking about reproductive risks and what the options are for that individual based on the clinical scenario, whether the gene that causes their condition is known or not, and what their personal beliefs might be. Genetic information is really important to share, particularly with at-risk family members, but it's also very private information. So we spend time talking with patients and families about what information should be shared, how it should be shared, who it should be shared with, and provide written documentation to help facilitate the communication of this information. And then finally, we talk a lot about identifying family members who could be at risk. And so identifying where they live, who they can see in their area, getting them referrals so that they can get access to appropriate care depending on the clinical situation. And then this is an ongoing relationship. So we follow patients and families through many, many years, many decades as their needs change, as their family grows, and as they age. Next one. And so some of the nitty gritty of genetic testing is coming ahead. Go ahead. When to test. So we get a lot of questions about when should we be ordering genetic testing. At UCSF specifically, almost all the genetic testing is done on an outpatient basis. And this is mainly because the results don't change medical management on the inpatient setting because they take too long. It takes about a month to get a panel back. And really rarely is the information going to directly impact the care in that amount of time. There are a few situations where genetic testing is advised in the inpatient setting and is available just within the UCSF system. And that's one if patient survival is unlikely or in question and the family wants that information. And then secondly is if there's some complex medical condition, a genetic syndrome, a metabolic condition, for example, that could be actually treatable, it could be useful. And usually a medical genetics consult in this setting is going to be more valuable than a genetic test that can make a clinical diagnosis or facilitate biochemical testing that could make the diagnosis in a timely fashion. Next. So there are a lot of different types of genetic tests, and I'll just sort of briefly talk about what these are and the advantages and disadvantages of them. Historically, genetic testing was a single gene test, one gene at a time, very, very costly, tens of thousands of dollars, like Vasanth said. That was usually done with Sanger sequencing, which we rarely use now. The panels that we typically order for clinical cardiovascular genetic testing are next generation sequencing panels of anywhere from a few genes to a few hundred. And the advantage of these is that you can test a lot of genes at a relatively low cost, and you have good coverage, both for sequence variants, single base pair sequence variants, as well as larger deletions and duplications. The downside of a targeted panel, though, is there's not flexibility. You basically have sequenced the genes on that panel at that time. As new genes are discovered, you have to repeat genetic testing. This is where sort of clinical whole exome testing has some advantages. This is where we basically sequence all 20,000 genes, the coding region of all 20,000 genes, but we only interrogate the gene of interest. And so a clinical exome compared to a panel for cardiovascular genetics really has limited additional yield because the panels are so broad and we've identified, and we know a lot of the genetics of cardiovascular, inherited cardiovascular disease. The upside of a clinical exome is that we can go back and look at the data. So as new genes are identified in decades to come, we can just go back to that sequence data and look. Unfortunately, the downside is that costs a lot of money and is not really well covered for patients with adult inherited cardiovascular disease at this time. So we typically stick with panels. Whole exome, where you're looking at all genes, or whole genome. These are research tools, so they're super valuable in gene discovery, but they do require some certain circumstances. We have to have a very high a priori suspicion that this has a single gene etiology and have the right family structure to be able to utilize these. Okay. So which genes should we test? This is very controversial, and in genetics, we could spend a whole lecture on arguing back and forth about should we have targeted or broad panels. But suffice it to say, it's a very dynamic process. Some genes get added because there are new data that show that there's conclusive evidence of a disease association. And on the contrary, some genes are removed from the panel because the evidence is disputed. Particularly as time has gone on and as we've learned more, the threshold for the association has increased. And so many genes that were once accepted as being associated with a certain condition based on presence in a patient or a couple patients are now disputed. So this is a dynamic process. And with that, the interpretation of the genetic test results changes over time. And that's something that we spend a lot of time looking back with patients and communicating with past patients to make sure that they have a good understanding of the current interpretation of their genetic test results. Next one. So this gets to sort of the muddy waters of genetic testing, and I won't go into the minutia of it, but basically, we all have a lot of rare genetic variation, as Vasanth pointed out, and our variation is indeed rare, so we don't share it with a lot of people. So when we go sequencing genes, and the more genes we sequence, the more rare genetic variation we find, it becomes difficult to categorize. For a while, basically, any gene variant that was found in a gene that has been associated with disease was considered disease causing, and that was it. In 2015, the American College of Medical Genetics put forth standards or guidelines for which we should be interpreting genetic data. And that's sort of what this summarizes. There are 5 categories of genetic variants based on the likelihood of the individual variant being pathogenic. And so the variants that are very unlikely to be pathogenic based on the data that we have about them, mainly the prevalence in the general population, would be considered benign or likely benign. And you're not going to see these on a genetic test report. We all have them, they're identified, but they're just not reported. On the flip side, gene variants that have a high likelihood of being pathogenic, anywhere from over 90% to over 95% are going to be considered pathogenic or likely pathogenic. And these are the actionable results that Vasanth was talking about before. So that leaves the huge category in the middle of variants of uncertain clinical significance. So these, as you can see, have a huge range of likelihood of pathogenicity. Some are very unlikely and probably are benign, and a few are probably pathogenic. Overall, for this broad category, as we learn more information, 80% of the time they get downgraded to benign or likely benign. It's actually quite unusual that they get upgraded to pathogenic. So just keep this in mind if you have a patient who has a variant of unknown significance, that it's going to be a little more likely, much more likely that it turns out to be nothing. Okay. So how do we deal with these VUSs within this broad category of suspicion? Basically, we collect all the lines of evidence that are available on an individual variant, how often it's seen in association with disease, if it has been, how often you see it in the general population, has it been reported in the literature, is there any functional data, and is there any segregation data that we can use to be able to determine if it's causative or not. All of these lines of evidence have limitations, and none of them is a standalone. They're all used in conjunction with one another to mount sufficient evidence to determine if an individual variant is pathogenic. Very few rise to the level of being suspicious enough to be able to reclassify or upgrade. And usually the ones that are, we can tell there are certain things about them that make them good candidates. And we have a family where there's enough affected individuals that we can establish co-segregation with disease. And that's what you see in the pedigree on the left, is the people who have a red in their symbol. Those are individuals with the condition, and the circled ones, they also have the mutation. So establishing co-segregation amongst multiple family members gives you confidence that this is indeed the causative mutation. Next. So I'm going to share a little detail about our data. The data I'm going to share you is over a 10-year span of 2013 to 2023. Keep in mind, this was a pretty dynamic time for us. Up until about 2018, I was the only genetic counselor seeing patients within the division. And now we have 4. So we have 3 on the adult side and 1 on in the pediatric heart center. that all provide clinical care to patients and families with genetic heart disease. Go ahead. So over this 10-year time period, we've counseled 3,500 patients. Of those, about 2,200 are considered affected, where they either have an established diagnosis or suspected to have a condition. And the different phenotypes are coded in related colors here. So you can see on the upper left in the red shades, these are going to be people with isolated and syndromic aortopathies. To the right of that in the green are the arrhythmia syndromes. Below that in the blue colors are the cardiomyopathies. And then there's some rare syndromes at the top, and then the coronary disease or dyslipidemias in the orange, which is a small slice, but an ever-growing population, which is very encouraging given the frequency of things like familial hypercholesterolemia and the actionability of genetic testing in that regard. The table on the right just has some numbers, just in case anybody in the audience is particularly interested in a specific phenotype and research ideas. Please reach out. We're always interested in your ideas and collaborating. Next. This is the age distribution of our cohort. You know, it's probably skews a little younger than the overall cardiology clinic, but it's broad. And I think this speaks to the fact that one, you're all identifying patients at any age with these conditions and recognizing correctly that age isn't the best predictor of mutation status, and genetic testing still has utility even older in life if a patient has family members or we need it for diagnostic purposes. This data shows on ancestry in our population on the left in our population as opposed to California and San Francisco. Most of our patients are internal review referrals from UCSF, but obviously UCSF has a huge catchment area as well, and we also get external review referrals anywhere from probably the northern border to Central California. Overall, this compares pretty well with both San Francisco and California, with the exception that we have a higher rate of European referrals at the expense of our Latin referrals. And we're working hard to figure out why this is. Is it a language barrier, an access barrier? But really need to focus on making sure that the patients that have access to our services and genetic testing represent that of California. One issue with ancestry that is very well known in genetics is that there's a higher rate of variants of unknown significance or inconclusive results in people who are of non-European ancestry. This is historically because we didn't have population data in as much population data in other ancestries. So if you have a rare variant and you don't have a population to compare it to, it's going to be of the US. Our data shows that certainly the rates are lower in Europeans than they are in African Americans and Asians, but it's not as different as we think. Go ahead. And here's the genetic data. So this shows our yield. The dark blue is going to be the pathogenic variants. The light blue next to it is the likely path. Those two together are actionable. On the y-axis, you can see the different phenotypes. They're sort of grouped together with the arrhythmia syndromes at the top, followed by the cardiomyopathies, coronary disease, and connective tissue disorders and aortopathies. Yield is highest in long QT and CPVT, not surprisingly. The yield in those two conditions, even though it's highest for us, is actually lower than the published yield, substantially lower than the published yield. Similar with HCM, our yield is a little low. ARVC is on the low side as well. That is really reflective of the fact is I think that providers are very judicious about referring patients for these conditions. If there's any degree of suspicion, even if they're not meeting clinical criteria, they'll often refer patients for genetic testing because of the utility if it is positive. One thing that surprised me looking at this data is that for the dilated cardiomyopathy, our yield is actually exactly in line with what the published yield is for familial cardiomyopathy when there's more than one family member affected. That yield in the published data is about 40%, which is what you're seeing here. In sporadic cases of idiopathic cardiomyopathy, it's only 15%. So this is telling me that the referrals that we're getting are your young, more severely affected, and those with family history. The last thing I want to point on this slide before we move on is the yellow. The yellow are the VUSs. And so they're just really common. And so you're going to see VUSs, and not to take them too seriously. As I mentioned before, they do get reclassified over time. We handle that within our clinical program. And vast majority of the time, they're going to turn out to be nothing as opposed to something of concern. These are the major genes that we have pathogenic and likely pathogenic mutations found, and these are affected individual probands as well as their unaffected family members. And so just in case anybody has some interest in a particular gene and wants to look into it, these are sort of the counts of some of the major long QT arrhythmia genes, dilated cardiomyopathy, ARVC, and HCM genes, as well as others. The next few slides we got from the genetic testing laboratory that we use in Vitae. And the first one just shows sort of our growth over year. A steady increase in tests sent. Last year would have been higher. We had some leaves that didn't get to accommodate quite as many patients as we'd expect, but we are showing year-over-year growth, and that is all due to all the increased referrals that you're all making. This is our volume in comparison to sort of other similar institutions that are of similar size and academic. And again, this really points out how good the providers are at identifying people who could have inherited heart disease and using genetic testing. So keep up the good work. This shows the panels that we order. The vast majority are this broad arrhythmia cardiomyopathy panel that you've all probably seen, the 100 gene panel. Next, aortopathy, and then lipid disorders, which are completely different genes. There are many different panels, as you can see, and some of them are very targeted to a specific disorder. I think there are clinical circumstances where we do really targeted genetic testing, but for the most part, for people who have arrhythmias or cardiomyopathies, we order a broad panel just to get a sense of the whole landscape of genetic variation. And this is a very encouraging slide. This is the data of the average cost of our patients last year. And what you can see here is 80% of our patients paid nothing for genetic testing. 10% paid under $100, and another 10% or so paid under $250. But for the vast majority of these patients are paying very little for a genetic test that has such huge clinical utility for them and for their family members. So hopefully this trajectory of decreased patient costs will continue into the future, but I wanted to kind of share that if people generally ask that information.
Thanks, Julianne. I'll take over for the last part. I just have a few slides to close this out, and we'll leave some time for questions. I think we highlighted some challenges that are sort of ongoing and that we're hoping to see improved over the coming years. So one is just variant interpretation in light of the diverse population we have in our catchment area. So I think as NOMAD and other databases are expanded, I think with people of non-European ancestries, the hope is that the VUS rates will kind of be the same across the board for everybody, and that variant interpretation will get easier actually for everyone as the databases expand. The other thing is, we've talked about yield a fair amount, and, published yield obviously varies by condition. Our yield may be a bit lower in some areas and higher than others. But it's a little unsatisfying that, a lot of people who we really strongly suspect have inherited heart disease don't have a detectable mutation with our panels. And so, some possibilities are maybe there's monogenic, there are genes we don't know about, and maybe with expanded testing using exomes, we'll pick those up. There could be other kinds of structural variants, non-coding variants, things that we don't detect with short read sequencing or with panel testing. It may be that deeper sequencing or thinking more about structural variation in the genome might be required to uncover the genetic basis for some patients. And obviously, people can acquire disease. And then a lot of disease is polygenic, and I'll get back to that in a minute, or multifactorial, or a result of gene-environment interactions, or oligogenic, and that's a big challenge for cardiovascular genetics. The other issue, this slide is called ascertainment issue. It could also be called, penetrance or expressivity issue. But if we do, this table basically summarizes recent data in which, if you look at family-based testing, so testing probands and then looking at the family members of those probands who have disease, for something like ARVC, about 31% of the genotype positive family members will have the disease, right? So giving you a sense that the penetrance is reasonably high for those people. But when you look at the population level and actually look at, what's the likelihood of disease in patients with PKP2 known pathogenic mutations, it's actually pretty low. So 6%, something like that. And it's similarly surprisingly low for other known pathogenic mutations. Now, some of that may be that patients aren't getting phenotyped, or patients are being assessed before disease onset. But it may also be that we're more likely to see the people who have the most severe phenotypes and the families whose genetic backgrounds or environmental situations are more, make them more prone to develop disease. So there are a lot of consequences to this. I think one thing is that, there are people who get direct-to-consumer testing of all kinds of varieties, and if they might panic if they find out, oh, you have a pathogenic mutation in a gene that causes ARVC, and that's associated with sudden death, et cetera. And certainly it's a reason for them to get worked up, but there's a 94% chance they're not going to have or potentially even develop the disease. The other thing in terms of opportunities, so I just mentioned population level data. So as we get better, higher resolution genetic data with really detailed EMR data as well, things like UK Biobank or even other databases, all of us, where there's clinical data that's pretty granular, as well as whole genome data, we'll get a better sense of penetrance and expressivity. We can understand the predictive power of different genotypes. We'll be able to probe gene, environment, lifestyle interactions, and even with outcomes define, optimal treatment strategies. And then I want to touch on an area that I think is growing extremely rapidly, but still hasn't quite made it into common clinical usage, and that's the sort of thinking about polygenic risk. So up to now, we've really been focused on monogenic and rare variants, which tend to have an effect size. One variant has a huge effect size, but they're pretty rare. Obviously, most disease that's inheritable or heritable involves common variants that individually have a very small effect size, but when added up together have a large effect size. And so that insight has led to the development of polygenic scores, where essentially people can have single nucleotide polymorphisms assessed across the genome. And in established cohorts with and without disease, the likelihood that each individual variant is associated with disease can be established. And then those risks can be added up into a polygenic score that says, for all the variation that you have in your genome, how likely are you to develop some phenotype, or where do you fall on the spectrum of risk? So that approach has is obviously attractive because you have the ability to refine risk for a general patient who comes into the clinic from the general population. But obviously it has some limitations. Ancestry is going to be very important, making sure that you have a polygenic score defining one population carries over to another. There's a lot of challenges in using that data. And then in thinking, how much does it add to just taking a family history or looking at traditional risk factors? So there are some uses. This is a recent, on the right, there's just a table from a recent document on the utility of polygenic scores in very particular diseases. But I think the key points are that I would emphasize are, one, the risk associated with people who are at the highest end of polygenic risk is often comparable to the risk of a typical Mendelian monogenic disorder. If you identify people in the top 1 or 2 or even 5% in polygenic risk, that can be a major heritable risk, even in the absence of a specific gene mutation. And, obviously this can enhance risk prediction, refine diagnosis and management. And, if ever this could be implemented on a population level, it could really blow open preventive cardiology. And, SNP ascertainment is not super expensive. And we have a pilot study kind of just getting off the ground, led by James Piricello and Evelyn Stock, to try to establish the utility of polygenic scores, or their predictive value, at least for lipids, in our very diverse cohort. And then finally, I just want to touch on genotype-specific novel therapies. So, right now, I don't know what the exact count is, but if you look across cell and gene therapies worldwide, it's something like 5,000 active trials. Obviously, that includes, mRNA vaccines and CAR T therapy and stuff like that. But even within the world of gene therapy for monogenic disorders, this is sort of becoming a real live possibility now. So just some examples would be the PKP2 ARVC mutation, where there's an agent that's being tested in gene therapy, and we're one of the centers. Likewise for myosin binding protein C3, HCM. Both of those studies are, we're one of the sites. And there's also things like MAP kinase inhibitor, currently in phase 3 for lamin A. And there's a gene therapy for Danon disease as well that I think is in phase 3 now, if I'm not mistaken. So, establishing genotypes, you could certainly imagine that cardiovascular genetics will move from where it is now, which is largely diagnostic, into something kind of really therapeutic, where we can actually deliver gene-specific correction or therapy in the future. So I just want to highlight the people who are involved in the Cardiovascular Genetics Center as of now. So I already mentioned I think Julianne mentioned that we have 4 genetic counselors who are also involved actively in research, as well as seeing patients. And then as of now, when I was at a faculty meeting, I just sent out an email saying, whoever wants to be a clinical lead in a given area, let me know. And these are the people who responded, but it's not necessarily restricted to these people. Anybody that wants to see, be part of this, or see inherited arrhythmia patients, or develop expertise in this area, is most welcome. And please feel free to contact us. We could always use your insights and input. And I just want to mention that, the original kind of infrastructure for this center was created by Mel Scheinman, as well as a lot of philanthropic funds over the years. And recently there's been a large infusion of philanthropic funding, which will support not only some limited amount of clinical effort, but a lot of research and development of educational programs and outreach, et cetera, et cetera. So with that, I will take questions.